The CMC gang, Varghese.
Yeah, it's CMC gang. BT, next week we take up 4 cases. 1 will be by LBK and 3 will be from my side. Okay, 20 minutes each. You got it?
I think he's unmuted.
Yeah, ma'am. I could not talk to you. Okay. Next time means. Okay. Next time means.
29th. Next week.
There is a problem. I will sort it out.
29th is madam.
Okay. You're audible. You're audible.
I am doing so many things simultaneously.
You have become a very busy man now.
No, I am trying to stream it to Facebook. So.
Why don't you have this Zoom? If you take the Google Meet.
Google, no?
Google Meet is best.
Okay, I will try to change over to that.
Many of us are doing on Google Meet only. It's very easy also to log in, and more than 100 people can join.
Okay. Professor Venkat, please upload your slides.
Okay, sir.
Okay, you're thing. I think you will start. Okay, no problem. Today we have Dr. Ravi Kiran from Mayot. Are you there?
Good evening,
Ravi
sir.
Kiran, are you there?
Yes, sir. Good evening.
Good evening,
sir.
Okay, Dr. Sadish from Pushpagiri.
Yes, sir.
Okay, fine. And if you have time, depending upon the time, Dr. Emnish, are you also there?
Yes, sir. I'm here, sir.
Okay, fine. And Dr. Aniket, standby. You are also
Yes,
there.
sir. I'm
Okay, everyone is there. Great. Welcome to our clinics. Let Professor Venkat come back. Sojan, are you there?
Yes, sir. Yes, sir.
Okay. Okay. Sir is there. Fine. Okay, good evening, everybody. Welcome to this session of ISGK PG Clinics. We have clinics today, and for our clinics, we have Professor L. Venkatakrishnan, the Professor and Head of GI Sciences of PhD Institute of Medical Sciences and Research, Coimbatore. Professor Venkatakrishnan has been with us for the last 6 months, taking clinics on a regular basis. And welcome, Professor Venkatakrishnan.
Thank you, sir.
And to moderate the session and to chair us and to give us special comments from his practical wisdom, we have a senior consultant gastroenterologist of Rajagiri Hospital, Kochi, Dr. Rosh Varghese. Welcome, Dr. Rosh.
Thank you, sir.
Okay, so without much delay, we will begin today's clinics. And to start with, the Dr. Ravi Kiran will be discussing. When Professor Venkat, if you want to split up the discussion to one candidate, a certain aspect, and if you want to hand over the remaining to another candidate, also we are ready. We have 4 people lined up. Okay.
Okay.
Now, Dr. Ravi Kiran will be doing the initial part. Okay.
Start, Dr. Ravi Kiran. I am audible?
Yeah, you are
Yes, sir.
audible, you are visible. Okay.
Okay.
And the house rule is that except the person who is actively discussing and the faculty who is actively discussing, all others are requested to keep the audio and video in the off mode. This is to save bandwidth. And when a question is asked, please don't prompt by giving the answer in the chat box. However, you can use the chat box to air your doubts, and faculty also can put in some different differential diagnosis which are not discussed during this discussion. Okay, again, once again, I request, please don't prompt with the answers when the faculty asks the question to the discussion. Over to Dr. Rosh. Any comments?
Hello, sir. We will keep following it, whatever you said.
Okay, then we will request Professor Venkatakrishnan to start. Over to Professor Venkatakrishnan.
Thank you, sir. We have 2 cases today. I think first case, Dr. Ravi Kiran, you can start.
Yes, sir. Good evening, sir. Yes.
Good evening. Please go ahead.
It's a 67-year-old female presented with progressive jaundice for the past 1 month and abdominal distension for 10 days, pedal edema intermittent for 3 months.
Yeah. This is what is a clinical presentation of a 60-year-old female. She has come to us with progressive jaundice. These are 3 chief complaints. Abdominal
Yes, sir.
10 days. But she says intermittently she was having pedal edema for 3 months.
Yes, sir.
So how do you expand on this history? You start with jaundice, you start with then come to abdominal distension and pedal edema.
So, prior to the jaundice, any history of prodromal symptoms like fever, nausea, loss of appetite?
There was
And-
no prodromal onset of jaundice.
Yes.
There is no fever.
Yes, sir.
Anything else you want?
So, any associated pruritus or pale
Yes.
stools?
She has been having pruritus for 6 months. 6 months. So pruritus has preceded the jaundice at least by 5 months. She has been having severe pruritus. I think. Anything else you want to expand on the pruritus? Any other questions? Any other
Nocturne.
questions?
Any
Pruritus.
fluctuations? I mean, waxing,
Yes.
waning of
Yes,
pruritus.
fluctuations. It is more in nocturnally. It has disturbed her sleep. It used to involve her palms, toes, and all over the body. So much so, she developed scratch marks.
Okay, sir. Any pale stools also, sir?
There was no pale stools, but she had 1 episode of melena.
Any prior abdominal pain? Anything?
There was no abdominal pain. There is no prodromal onset. There is no fever. There is no abdominal pain. The only abdominal pain she says is the dragging pain when she developed this abdominal distension. But she never had any acute abdominal pain.
Okay, sir.
Anything else?
Any history of complementary alternative medicine intakes?
Let's finish off.
Any-
Let's finish off this.
Jaundice, yes, sir.
No, let's finish off rest of it. No, you have abdominal distension. You have pedal edema.
Yes, sir. abdominal distension, uniform distension, or any?
It is a progressive distension.
Any-
Slowly, it came to a point where she felt a lot of discomfort, so that she was referred to us.
Yes, sir.
Anything else you want to associate with abdominal distension? Should ask for associated pain. Is there any associated pain
Associated pain.
at the onset of abdominal distension?
Yes, sir.
Was abdominal distension became massive, or is it moderate? Okay.
Yes, sir.
All those questions we need to ask. Abdominal distension can be fluid or even
Gas.
gas. So was abdominal distension associated with any intermittent abdominal pain? Was it gradual in onset? Was it associated with vomiting? All these things need to be asked. Okay.
Any decrease in, abdominal distension following vomiting, if anything.
There was no vomiting. There was no abdominal pain. It was a gradual abdominal distension, and she got the discomfort when it reached a certain point.
Yes, sir.
But she was
tracking
having intermittent pedal edema for 3 months. On and off, she used to have pedal edema, and the pedal edema used to go off whenever it was a postural edema. But for the last 20 days or 4 weeks, the pedal edema was persistent. Okay.
Sir.
So can you summarize here about this history? No, I'm summarizing means just these points. Can you tell what are the salient points?
Yes, 61-year-old female coming with the history of prior history of progress, followed by progress development of insidious onset of jaundice and progression for the past 1 month, and abdominal distension, initial insidious onset, again progressively increasing, uniform distension, not associated with any abdominal pain or vomiting, and pedal edema, which was intermittent initially. Initially it was postural, and later now continues for the past 20 days.
Yeah.
So
There was
probably
one other symptoms.
one is
We said there's no fever, there's no arthralgia, no prodromal. One episode of melena.
any history
Any
of,
other symptom complex you need to ask?
any history of oliguria or altered sensorium?
There is no history, correct. There is no history of altered sensorium. So altered sensorium is something important. And she has been passing urine. She does not really complain of oliguria. Every day she says she may pass half a liter of urine.
Yes.
So go to the next slide. There was no prodromal onset. There is no fever, no arthralgia.
At melena, one episode.
One episode of melena. No vomiting. There was never associated abdominal pain. But she had pruritus for 6 months, more in the nights, which preceded the jaundice by about 5 months. Right?
Yes, sir.
And there is no clay-colored stools, according to her.
Yes, sir. With this,
anything else you want?
Prior history of jaundice, sir.
Prior history of
jaundice, sir.
Prior history of no
jaundice
prior history of,
or any
no prior history
jaundice
of
or similar
jaundice,
abdominal history,
no
sir.
prior history of
Or abdominal distension previously.
No previous history of any surgery. And there are no risk factors for chronic hepatitis. She didn't have any tattooing. What are the risk factors you would like to ask?
Prior history of blood transfusion,
Good.
surgery, tattooing,
Then
or
risk
any
factors.
high risk.
High risk
dental
behavior. 67 years, no? 67
Yes.
years, no?
Yes. Previously,
And any history of? Okay. So this is her thing. So she has been having a progressive jaundice. Prior pruritus preceded jaundice by 5 months. Now, after 20 days of jaundice, she developed abdominal distension and she had intermittent fetal edema.
Past history. She is a diabetes, diabetes mellitus for 22 years on oral medications, and she underwent coronary artery bypass surgery 12 years back and on dual antiplatelets and statins. Has diabetic nephropathy with CKD stage 5 for the last 2 years with creatinine of 5.1. Was admitted in a kidney care center now and transferred to us due to altered sensorium and melena.
So this is her history. So she's a diabetic. She's undergone a CABG 12 years back. She is in stage 5 creatinine fibing. Was admitted to kidney care center now and transferred to us because she had one episode of melena, and they found that she was probably mildly altered sensorium, so she was transferred to us.
Patient pruritus worsened.
And the jaundice became pruritus worsened.
He has been on CAM for complementary alternative medications for 3 months before the onset of jaundice, and also took another set of 21 days after the onset of jaundice. No history of any treatment for thyroid disorders. No history of any previous jaundice.
Ravi, please mute your video. There is some audio disturbance. Can you mute your video? Okay, fine.
Yes,
Continue.
Patient pruritus has worsened. He has been on CAM for 3 months before the onset of jaundice, and also took another set of CAM for 21 days after the onset of jaundice. No history of any treatment for thyroid disorders. No history of any previous jaundice. Nutrition history: poor salt intake for the last 1 month due to abdominal distension and low salt.
Okay.
Yes, sir.
What has happened now?
Yes, prior to the jaundice itself, she has been on alternative medications for 3 months, and after the onset of jaundice, again she has taken further another course of alternative medications, sir. And so,
No history of any treatment for thyroid disorder. What is it important?
probably any history to get any association for autoimmune disorders, for autoimmune liver diseases, and like autoimmune hepatitis or primary sclerosing cholangitis.
No previous history of jaundice. So what are the issues here?
Start issues with pruritus, jaundice.
She had intense pruritus for 6 months. Then
Yes, the pruritus, and then worsening jaundice for the past 1 month.
she took CAM for 3 months.
Yes, sir.
Come in order.
Yes, sir. Pruritus followed by intake of CAM, then followed by onset of jaundice, then another round of CAM for 21 days after the onset of jaundice, then abdominal distension, and abdominal distension for the past 10 days, and intermittent pedal edema for 6 months. Now,
Pedal edema, 10 days.
now 10 days worsening.
Abdominal distension, 20 days after the onset of jaundice. Persistent pedal edema. Then
And now history of 1 episode of melena and altered
melena
sensorium.
followed by
Altered sensoriums.
altered sensorium. What are the comorbidities she has?
She with her comorbidities of diabetes for the past 22 years, long-standing diabetes, and history of coronary artery bypass surgery on dual antiplatelets and statins.
Okay. And she has got
with poor nutritional intake.
no, she's got chronic kidney disease.
Chronic kidney disease of stage 5
Stage 5
creatinine
with a creatinine of
5.1.
Okay. So what's happening here? So the comorbidities are diabetes, coronary artery disease, on statins. She's got stage 5 kidney disease. The other issues are pruritus, CAM, jaundice, ascites, pedal edema, altered
Alina.
bleed, and altered sensorium. So what's happening?
Probably a drug-induced liver injury with decompensation and form of associated with GI bleed and altered hepatic encephalopathy, probably.
So drug-induced liver injury producing decompensation. So
Yes.
that means acute hepatitis, which has gone on to decompensation.
Yes, sir. Yes, sir.
You have conveniently forgotten pruritus for 6 months.
Yes, sir.
57-year-old lady comes with pruritus, then has there's no abdominal pain, comes with following CAM sheet, has jaundice, and then she decompensates. So how do you? So there is pruritus for 6 months, history of CAM, then progressive jaundice for 1 month. Within 20 days of jaundice, she has an abdominal distension, pedal edema, and she has GI blood and order. So you said there is drug-induced liver injury.
Yes. But pruritus is not a control.
How do you correct pruritus and progressive jaundice with the intervening CAM? What could have caused pruritus in this patient? Please let me know. What are the causes of pruritus could have happened in this patient?
Be hepatic related, non-hepatic related. So hepatic related, probably intrahepatic pulse.
Severe diabetes could have caused pruritus, no?
Yes, sir.
Uremia could have caused pruritus, isn't it?
Yes, sir.
If it is, okay, so non-hepatic, both diabetes or chronic kidney disease could have caused
Yes, sir.
pruritus. Now, hepatic?
Hepatic, probably intrahepatic causes of intrahepatic related pruritus. So.
Intrahepatic cholestasis.
Yes, sir. Intrahepatic cholestasis. Probably.
What could have caused pruritus if it's intrahepatic? What are the causes of intrahepatic cholestatic disorders which could come pruritus?
Yes, sir. There
Preceding jaundice.
Infections, inflammatory disorders, or classifying it as infections, inflammatory disorders.
Which infection comes with pruritus and then jaundice?
Tuberculosis can cause this. Hello?
Tuberculosis, how does hepatic tuberculosis present?
Actually, loss of appetite, then
fever, no? They'll have fever, all those things.
Systemic.
So if somebody has got 6 years, got pruritus for 6 months, you think should have gone on without anything for pruritus for 6 months in tuberculosis, without fever and systemic symptoms, without cough?
No, sir.
Yeah, please think about all these things. No, so if you have pruritus in a 67-year-old lady who develops jaundice, what are the causes? Just name the causes. Name 3 immune-mediated related, four immune-mediated related where they can come with pruritus before jaundice. Three.
Primary sclerosing cholangitis, sir.
First, in a middle-aged lady, the first thing is
primary biliary
cirrhosis. It's much more commoner in
females.
And there is an associated diabetes, isn't it?
Yes, sir.
Number 2.
Primary biliary cholangitis and primary sclerosing cholangitis.
Then
even autoimmune hepatitis.
Autoimmune cholangiopathy.
Cholangiopathies.
Then what else can produce pruritus? What infiltrative disorder can come with pruritus, raised alkaline phosphatase? In a middle-aged lady or elder.
Sarcoidosis.
Sarcoidosis then.
Amyloidosis in CKD patient also.
Okay, amyloidosis then. Should be very, very wary of lymphomas. Okay,
Yes, sir.
right?
Yes, sir.
But so these are things which could have so this patient could have had an underlying primary visiting PSC or autoimmune or a sarcoid. And what has now, so what has the CAM, how has the CAM impacted her?
Probably CAM must have accelerated the cholangiocyte injury into progression to jaundice and
CAM could have
decompensation.
caused drug-induced liver injury,
Yes, sir.
and patient could have
Presented with jaundice and developed hepatitis and decompensated for
she didn't have any features of hepatitis. She had only cholestasis. Then she would have
jaundice.
decompensated because of a drug-induced liver injury.
Yes, sir.
And because of the drug-induced decompensation, she could have developed a
GI bleed with
GI
hepatic
bleed,
encephalopathy.
and bleed could have precipitated a
Hepatic encephalopathy.
hepatic encephalopathy. Okay. So that's the one problem is this could be a problem. So you can have had an underlying liver disease, which could have been intrahepatic cholestasis because the pruritus was intense for 6 months. Then there was a CAM which was taken. Okay. After jaundice also, she took some CAM for 21 days.
Yes.
So both this CAM could have produced an intense drug-induced liver injury and thing. What is the cause for ascites? Patient has developed progressive abdominal distension
And pedal edema also. Yes, sir.
and pedal edema.
Probably a liver decompensation, sir.
One is liver decompensation. Number two, liver decompensation due to what? What could have caused
Due-
ascites and liver decompensation?
CAM intake could itself precipitated
Could have
decompensation.
produced an ACLF.
ACLF picture. Yes, sir.
Number two, patient we thought has got an underlying liver disease. So what can she have? When somebody has got underlying chronic liver disease, what is the other thing you will always get? Portal hypertension, isn't it?
Okay. Yes, sir.
So, so the inflammation could have driven the portal hypertension, and because of portal hypertension, she could have had developed a
Ascites and GI
yeah,
bleed.
and then variceal bleed, then altered sensory.
Altered sensory.
These are three things I think. So, do you think this is an acute on chronic liver failure?
Is it possible, sir? Because she had
could be possible. So she might have, because the pruritus is extending, she may have had some intrahepatic cholestatic disorder like an immune-mediated liver disease or an infiltrative liver disease or a lymphoma or something. But it's going on for 6 months, so lymphoma is not a usual thing. And then an intervening CAM for her symptoms have resulted in her decompensation. And she developed jaundice because of drug-induced liver injury, and within 20 days she developed ascites, so altered sensorium and GI bleed. So that means there was an organ damage, and this could be probably an acute on chronic liver failure. Precipitant being
CAM intake, sir.
CAM. That is what. So what will be your
Hello, yes, sir.
something has happened. Okay, once sorry. So we discussed the provisional syndromic diagnosis.
Yes, sir.
What happened? What happened?
Any problem, Ravi? Are you there?
Yes, sir. I'm there, sir.
Okay, I think, yeah, Professor Venkat, you are.
My screen sharing. What happened? I don't know.
Okay, please. Something has happened there. It is your desktop only. I think,
Yeah, 1 minute, sir.
okay, it's no problem.
I'll just stop sharing and come back again, please.
Okay.
In the meantime, Ravi, what are the types of liver injury you can get due to CAM? Various types. How do you classify the liver injury due to CAM?
Idiosyncratic reaction, ma'am, and
What are the various types?
No, something happened. I don't know.
Your desktop actually shows your case. Yeah.
Click on that. That's not working. Can you click on the Microsoft PowerPoint icon, which is blinking
Yeah, I
in the
think-
lower part of screen?
What
I think
happened?
Lower bar, no, sir. Like there is a PowerPoint screen. PowerPoint. Yeah, click on that. Can you please click on that, sir?
Yeah, click on that.
Yeah, if you can click on that, that will come.
No, no.
Not this one, the other one.
Not this one.
Not this one, the other one. Close that, close that.
Yeah. Not this one.
Close it.
Venkat,
Yeah, yeah.
just look at that file and then just click that file. Then you have a list of things which you have opened recently. On the top of your PowerPoint, just click file.
Rest
Then
it
you
is.
find,
Vicky, let him send it to you and you share it. That's easy.
Yeah, yeah. Got it.
okay.
Where is enable editing?
Then just open. Click your slide. Click on slide number 8. Slide 888.
Back.
1 minute, 1 minute.
Back.
Yeah. So we discuss the possibilities. So what are the possibilities and what is a provisional syndromic diagnosis you can offer here?
provisional syndromic diagnosis would be acute and chronic liver failure, sir, because of the onset of jaundice within 4 weeks development of ascites and encephalopathy.
Acute and chronic liver failure. So what could be the causes of chronic liver disease in this patient?
Chronic liver disease, first possibility I would like to consider non-alcoholic state of NASH related, sir, because she's been a long-standing diabetes.
Okay.
Then possibly still since he had pruritus, possible
67-year-olds,
immune-related
you can always consider chronic viral hepatitis, Hep B and Hep
chronic
C.
Biopsy. Then autoimmune liver disease because of the autoimmune primary biliary cholangitis and primary sclerosing
Because of
cholangitis.
pruritus, immune-mediated liver
PBC,
disease, it could be PBC,
PBC,
PSC, autoimmune cholangiopathy, and infiltrative liver diseases,
infiltrative liver disease like sarcoidosis, lymphoma,
sarcoidosis,
lymphoma.
lymphoma. Then you said amyloid,
Yes, sir. Yes, sir.
isn't it?
Yes, sir.
Then never omit Budd-Chiari in these patients. Okay,
Yes, okay. I'm related. Yes, sir.
Budd-Chiari in these patients. So what will these may be the chronic liver disease? She may have an ACLF.
Hello.
Precipitate trigger factor being
Ravi, can you hear?
Hello.
We can't hear you, Dr. Ravi Kiran.
Second candidate, no?
Yes, sir.
Let's move
Yes,
on
sir.
to the next candidate.
Dr. Sadish, please,
Sir, hello.
please answer. Okay.
Trigger factor being, yeah, CAM. Does she have
Yes,
portal
sir.
hypertension?
Yes, a possibility of portal hypertension because she has developed ascites and variceal bleed,
And hepatic encephalopathy.
hepatic encephalopathy. Yes.
Comorbids being
Diabetes and long-standing diabetes and coronary disease in the form of CABG and then CKD stage 5.
So this will be the symptom. So investigations done outside. Yeah, go ahead, please.
Yes, sir. Investigation done outside. Total bilirubin of 22.1, direct 20.2, SGPT 46, SGOT 57, alkaline phosphatase is 169, gamma GT 236, prothrombin with INR is 1.46, hemoglobin 7.3, platelets 1.62, 1,62,000. And ultrasound abdomen showing normal size kidneys, mildly coarse liver with moderate ascites. CT plain abdomen, mild surface nodularity of the liver, portal vein 13 millimeter diameter, and ascites present. MRCP was normal.
It was an outside. Somebody said because she had a severe pruritus, they did an MRCP.
Yes, sir. Which was normal.
Investigations here.
Platelet count is normal. Sir. So
Platelet count is, yeah. 1,62,000, yeah.
yes, sir. It's normal.
You're not audible, doctor.
Yes, sir. Yeah, it's a normal platelet count. I was just thinking portal hypertension, there should be thrombocytopenia.
Who is speaking, Ravi?
Sir?
Who is talking now? Who is discussing, Ravi?
Ravi Kiran, sir. Yes, sir.
Okay, fine.
Yes, sir. Hemoglobin is 6.
Platelets are normal. Let's take it from here. Okay. We thought there'll be a portal hypertension. See, your syndromic diagnosis is the end of the history.
Yes, sir.
Oh.
Yes. Complete blood count. Hemoglobin of 6.3. Pack cell volume 18.6. Mean corpuscular volume 83.4. Total WBC count is 16,300 with predominant neutrophils 88%. Platelet count of 3.38 lakhs and INR 1.1 prothrombin INR. Peripheral smear showing mild poikilocytosis, neutrophilia, and shift up to left up to myelocytes stage. Blood group O positive, urea 42, creatinine 5.09, sodium 133, potassium 4.3, bicarbonate 13.2. Here she's having severe anemia, sir. Hemoglobin 6.3 with leukocytosis, predominant neutrophils.
Which is
Normocytic, actually.
normocytic, yeah.
Yes, sir. And leukocytosis, predominant neutrophils with a normal platelet count and normal prothrombin with INR. And peripheral smear showing neutrophilia and with a shift, left shift up to myelocyte stage.
No. Suggest you all?
Either because of this, some sepsis component can be, there can be left shift of neutrophils, or could be a myeloproliferative disorder, chronic myeloproliferative disorder like.
It could be a myeloproliferative, or there could be a sepsis, which could have been.
Sepsis related.
Okay.
Yes, sir. Yes, sir.
What else do you want? Next investigation, what else?
Since she has a GI bleed, a history of GI bleed, I would like to do an endoscopy.
She had one episode of melena.
Yes, sir. One episode. Liver function test, bilirubin 16.2, direct 14.1, SGOT 41, SGPT 50, alkaline phosphatase is 226, total protein 6.2, albumin 3, gamma GT 321. It's elevated.
So the picture is what picture?
It's a cholestatic picture. So
it's a cholestatic picture. Okay. Serum ferritin 963.
963 and LDH of 321. TS 46.
Serum ferritin is 963. Then
ascitic fluid, albumin.
No, what next? TS 46.
TS 46.
What is TS?
Transferrin saturation. So.
High, low.
46.
Normal. When do you think transfer saturation will be significant? How much is significant? Dr. Ravi Kiran?
Yes, sir. Yes, sir.
More than 52. Okay.
Okay, sir.
Yeah, go ahead.
Ascitic fluid showing total protein of 1. ascitic fluid showing total protein of 1.72 with albumin of 0.94, total count of 90 cells with 20% neutrophils.
What does it suggest?
It's a high SAG and low protein, sir. With
It's a high SAG, low protein diet.
Yes, sir. And normal total count.
And
90,
no SBP.
no SBP. Yes, sir. And urine protein showing nitrites 3 plus and urine PCR 2.2.
Urine PCR
Protein
2.2 suggests
yes.
what?
Proteinuria, I mean, more than 0.3 is suggestive of nephrotic. More than 0.3 PCR is suggestive of a nephrotic type of.
Why is it she's got a PCR 2.2?
Because of the presence of CKD, there will be albuminuria, sir.
She's got diabetic nephropathy. Okay.
Nephropathy.
She's got a diabetic nephropathy. And nitrate positive may suggest
Urinary tract infection.
urinary tract infection. Okay.
Yes, sir.
So what do you do now? You send a urine culture. Then what else you want?
MRCP is normal.
What are the other investigation you want on her? So she's got a cholestatic picture. She has got a high serum ferritin. Transverse saturation is 46. She has got a high protein, low protein, high SAG ascites with no SBP and possible UTI with proteinuria suggestive with the outside ultrasound showing normal size kidneys. Possibly she's got a diabetic nephropathy. Okay. What else you want now? Next set of investigations, please. Quick, doctor, please.
Viral markers I would like to do. So hepatitis B, C.
So what all you want? You please tell me.
Hepatitis HBs surface antigen and anti-HCV antibodies, sir. And
You want HBsAg, HCV
anti-HBs
negative.
Yes, sir.
Yeah. HBsAg, HCV negative.
Yes, sir. And
Hepatitis A, E also we checked. That's also negative.
yes, sir.
What else you want? You said the patient could have hepatitis B or C.
So anti-HBC total.
Anti-HBC total was positive. What do you do when somebody's got anti-HBC positive?
Could be a resolved.
So what do you do? Yeah, it could be it can't be resolved. It could be an occult HBV infection.
Occult HBV infection. Yes.
What do you do next?
So,
How do you confirm it?
Hepatitis B virus viral loads. Let's ask for it.
HBV DNA viral load was negative.
So,
What else you want? So viral hepatitis is gone then.
PC is gone. Cholestatic picture. MRCP normal.
MRCP is already normal.
Normal. Intrahepatic cholestasis. So, like.
What is the other investigations you want? You said viral. Viral, we have given you everything.
X-ray chest for any mediastinal lymph nodes, sarcoidosis.
No, you said viral serology is negative. Your differential diagnosis, it said chronic liver disease was NASH. It was viral. Number 3 was immune mediated. Patient had pruritus for 6 months.
Yes. Autoimmune profile.
What do you want in autoimmune profile?
ANA. Then ask SMA SMA ANA, ASMA, and AMA.
Viral serology was negative. AMA M2 was negative. SLA was positive. LKM was negative. ANA IF was negative. Profile was negative. IgG levels were elevated, 26.2. Total anti-HBC was positive, but DNA viral load was negative. Should we do a HCV RNA in this? Can hepatitis C produce pruritus?
not okay.
Can hepatitis C produce pruritus?
In cryoglobulinemia,
Can hepatitis C produce pruritus? That's my question.
yes, sir. Yes, sir.
Answer Ravi just said, do not know, sir. No, you're the way it looks as you're not there.
You are not audible first, you know.
Yeah, that's why you're so hesitant. No, the next candidate, I think the next candidate can just take over.
Hepatitis C can also, the two things we should always, why we check for hepatitis C, HCV RNA. Why should we do HCV RNA in this setting? For two reasons. One, hepatitis C can come with pruritus, no? Have you heard that hepatitis, supposing a young lady, pregnant lady, during her 8th week of pregnancy is HCV positive, what do you anticipate in 3rd trimester for her?
Intrahepatic cholestasis of pregnancy.
Huh?
Intrahepatic cholestasis of pregnancy.
ICP. So you can get ICP of pregnancy. So you can get pruritus. Second thing is patients with diabetes mellitus and renal failure may not have that much of an antibody response. So you need to check HCV RNA in this patient. So both HBV DNA and HCV RNA were negative. Here AMA, M2, SLA was positive, but serum IgG, what is your comment on this?
It is elevated, sir, serum IgG, immunoglobulin.
So what do you get from this profile?
So hypergamma-globulinemia.
That's okay. Hypergammaglobulin and SLA positive. What can it suggest to you?
Possibility of autoimmune hepatitis is yes, sir.
Possibility of autoimmune liver disease could be an underlying liver disorder. Okay.
Yes, sir.
What else you want now?
As for liver ultrasound abdomens.
We couldn't do a CT because she had a renal failure. MRI abdomen also we didn't do because they felt that contrast could have exacerbated. She's not on any dialysis as it is.
Yes, sir.
So what does ultrasound show?
Venkat, do you want to take the next candidate? We'll give rest to
Anyway, sir,
Devi.
whoever it is.
Okay, Dr. Sadish, are you there?
Yes, sir.
Okay, please take over.
So Dr. Satish, tell me. So here is you have listened so far, no?
Yes, sir.
So we are thinking of an ACLF with an underlying chronic liver disease. We have ruled out viral. We have an autoimmune profile in one. IgG is elevated, LC1 is positive. And what does this ultrasound show?
Sorry, sir. I am not able to interpret.
You're not able to interpret. What is this? Gallbladder is thickened.
Yes.
There is ascites and mild coarsening of the liver. There is some. And here, what is this? What are we looking at this?
It's a Doppler.
What is it? I'm interested in Doppler. This patient. In Doppler of this patient, what are things? Which are the vasculature you will see in this patient based on the differential diagnosis we discussed?
It's a portal vein.
Portal vein and
Hepatic vein.
be confident here.
Yes,
What
sir.
do you think? We have said there
Sir,
is
portal vein and
look at the portal vein to look for a dilatation. You
Yes,
look
sir.
for a spleen. You look for collaterals. Patient has got ascites. He's got a mild coarsening of the echo texture. Her hepatic
Yes,
veins are patent. Okay.
Yes, sir.
Portal vein is dilated.
USG showing edematous gallbladder with wall thickening, liver echostructure mildly coarse, and bilateral medical renal disease with a moderate ascites and small umbilical hernia. Portal vein size is 13 millimeters.
So hepatic veins are patent. That means an IVC was patent. That means there was no Budd-Chiari.
Yes, sir.
What we saw was a coarsening echo texture of the liver, mildly coarse, chronic medical renal disease, moderate ascites, small umbilical and portal vein is this thing.
Yes.
What else you want? So she has some element of chronic liver disease. Portal vein is dilated. There was ascites. There was no spleen. There were no collaterals around the spleen. She has had one episode of melena. What else you will do next?
I'll, go for a ogitiscopy, sir.
What do you see here?
It's a small varices, showing small varices.
Varices are there.
Then might be altered blood.
Altered, good. Altered blood.
Then so,
You couldn't really see the fundus.
yeah,
This
yes.
one is
Second.
what is this?
D2,
What is it?
sir, it's D2. It's showing.
Yeah, duodenum with
So,
the villi are flattened, the folds are flattened.
yes, sir.
Could be a portal
Folds.
duodenopathy or something. Okay.
Okay.
So she's got a small varices. That's what we couldn't see really the fundus. This one
Yes.
and this was there.
Upper GA-scope is showing lax lower esophageal sphincter, erosive esophagitis, prominent lower esophageal veins, mild portal gastropathy, and incomplete screening of fundus because of stagnant fluid
So
or
now,
altered bloods.
okay. So now the problem, what are the, just enumerate the problems she has. She's a diabetic. She's got a chronic kidney disease. She's got a post-CABG status.
With ACLF, most probably secondary to acute autoimmune hepatitis and GI
She's got
bleeding.
a chronic liver disease, number one. She's got portal hypertension. Okay.
Yes. Yes, with the
She
GI
had
bleeding.
altered sensorium. And the chronic liver disease could be
Autoimmune
autoimmune
hepatitis
liver
induced.
disease. Possible autoimmune liver disease because she has a diabetes for a long. She's got AC1 and IgG. Is what? IgG and IgG and LC1 are positive. But globulins are not this one. And she has had a normal MRCP.
Yes.
Okay. And her ascites is low protein.
High sag ascites.
Low protein, high sag ascites. And then does she have ACLF?
Yes, sir. She's having ACLF. I can. It's a case of ACLF because it's a maybe underdiagnosed CLD, chronic liver disease, which is
So she's got a chronic liver disease because of the fact that she has probably
increased
liver. Now we have told why she's got a portal hypertension. Now she's got decompensation, could be due to a drug-induced liver injury.
Yes, sir.
And this can qualify itself into an ACLF. Okay.
Yes.
So she is admitted into your care. How do you manage this patient? At this point, at this stage, let's go. We got still some more to go in this case. Just tell me the principles.
The principles first is
edema. She's got jaundice. She was on native medicines. She had a bleed. She has got encephalopathy. Number 1, 2, 3, 4, 5, 6. You tell me.
First is its circulatory status. Assess the circulatory status.
That's all normal. Hemodynamically stable.
Okay. Then nutritional and general care.
For a bacterial screening, does she have an infection? She had a nitrites which are positive. Okay.
Yes.
So what will you
infection? I will start on empirical antibiotics.
will you send any cultures or you will not send?
Yes. No, sir. I will send cultures and start on empirical.
What cultures use?
Urine cultures, blood culture.
Total count showed a shift to the left, isn't it? With the
ASF. Yes, sir. ASF cultures. 3 cultures I will send, sir. Acidic fluid, blood, and
blood culture. Acidic fluid, of course, there is no SBP. Okay, we'll send cultures, and then you wait for it, and you start on antibiotics. Okay.
Yes.
Okay.
Then
nutrition.
Nutritional care. I will.
This patient has got a chronic kidney disease, diabetic
Yes.
nephropathy. So what will be your thrust on the nutrition here?
Lows. It's calories of 25 to 35 kilocalories per day with a protein of 1.5 gram per kg. Then
What is the problem of giving too much protein in diabetic nephropathy?
so more proteinuria.
There's already a proteinuria.
Protein.
Number one. What can protein overload do to
It's
GFR? See, when you give a lot of protein in a diabetic nephropathy, there will be hyperfiltration of the glomeruli, and you are going to still push the glomerular sclerosis, right?
Oh.
So you need to really do not give. We will not be able to, in the presence of nephropathy, we will not be able to give that 1.5 grams. But you got to really balance the protein. Number one. Number two, fluid and salt restriction. Okay.
Yes. Yeah. Fluid and salt restriction. Then so in the protein which we use, we can use for a soybean based because of.
No, that's okay. Nutrition, you go carry on. Okay, nutrition, you take care. Then what else?
Then
She has bled.
So I will plan for a OGD-scopy.
We have done the OGD scoring. There's only
Yes,
grade 1
EVL.
bar. We don't see a red whale sign in that. She's got a portal gastropathy. Yeah.
I will start on terlipressin, sir.
She's had a very minor bleed. I don't know the octreotide petrol thing. Okay.
Then HB is low, so blood transfusion can be in 4 points. HB is 6.3. So
okay.
I will give blood.
Okay.
And we will keep it in 7 to 9, in between 7 to 9. Then I will treat the specific etiology. In this patient is age, so I will try to consider steroids for a specific.
Straight away.
No, sir. Already I started on
LC1 single positive and IgG 26. So you want to start her steroids. Do you think you should put an autoimmune score on her? How do you put an autoimmune score? How do you do the modified autoimmune score? So you are very sure at autoimmune. So how do you come to a diagnosis? Just because LC1 is positive, or do you think we should put autoimmune score and say, is there autoimmune hepatitis, or is it probable, or it's definite?
Yeah,
you know that scoring, the German scoring.
Sir, it's more than.
No, you tell me what are the things in autoimmune.
Sir, autoimmune scoring, one is autoantibodies. We will say autoantibodies like ANA, SMA, and then anti-LKM bodies, anti-SLE. Then immunoglobulins, which we checked. Then it is more than.
IgG is 26. And how many? You require liver biopsy in this.
Liver biopsy, it's SLA2.
No, you tell me you know it, or you go back and read about that autoimmune hepatitis scoring, then do a modified scoring and say, okay.
Okay, sir.
Less than 2 is negative, 2 to 4 is probable, 4 to 6 or 6 is definite autoimmune hepatitis.
Okay.
You just can't say LC1, just one positive, I think I'll go and you can do steroids on her. I tell you why you don't want to. You're sent for a bacterial screening, you're given her antibiotics, and do you want to give her anti-coma measures?
Yes, sir.
What will you give?
Sir, we'll start on lactulose.
How much of lactulose you'll give?
Sir,
you'll ensure.
Sir, 20 to 25 ml 2 to 4 times daily, and make sure that it's 2 to 3 stools per day. Then I will maintain 2 to 3 stools per day.
What is the problem of too much of lactose?
That it may, one is abdominal bloating, distension. Then it's going to dehydrate.
You want to give
lactitol, then.
Or you want to add something else?
Yeah, sir. Rifaximin I will start, sir. In 400 mg TAD dosage or 550 BD dosage.
What about Lola?
Lola I won't start because of it's a renal failure, sir. So Lola won't be.
What is the role of Lola in encephalopathy?
Yes, Lola, it will
So is there a rule?
increase.
Is there a rule?
No, sir. Lola is not effective in ACLF.
So you
hepatic
take her, you stop the offending drug, do a bacterial screening, send the cultures, empirical antibiotics, nutrition, number 2, anti-coma measures, and then you probably can start operate or something because you bleed, but this bleed was not.
Sir, so then organ failure. We'll take care of the organ failures and complications. And step
No,
is.
she's got a CKD. She's got a creatinine 5. So what will you do?
So I will go for a renal replacement therapy.
She is putting out 800 ml of urine per day. And she was not obviously acidotic. She was well compensated. So the nephrologist said no need for this.
Sir,
I have worsened her creatinine when admission was 5.
Yeah, so then it will be sir, it will be a ACL. It will be considered as an organ failure in ACLF. So I will consider.
The patient is not a CKD, doctor. The patient is already known diabetic nephropathy 2 years before the onset of this pruritus.
Okay, sir.
Think about it. So this CKD wasn't mainly because of the drug also. There could have been underlying CKD. I've told you patient had 2 years before diabetic nephropathy and CKD.
Okay, sir. Then so I will
the patient.
Then I will.
Hello.
So, yeah, hello, sir. Patient had a course in the hospital. Patient had a slight drop of SB and also increased total counts. Bilirubin increased to 22.8 and total counts of 30,000 with the procal of 2.2. Then urine culture showed Enterococcus faecium and treated with the linezolid. Total count regressed to 18,000 and bilirubin persistent at 22.8.
Yeah. So this is what happened. So she had a infection, and the infection was treated. We thought that bilirubin just went up because of infection, but after after 72 hours of linezolid, the urine culture was negative. Total count came down to 18,000, and total count persisted at 18,000. Procal dropped to 0.6. Bilirubin was 23. Persistent bilirubin.
Sir, I will calculate the ARC score if it is.
What is our score?
Sir, it contains a PTNR and bilirubin and lactate, creatinine and hepatic encephalopathy.
What does it say?
So it's a stage 1, 2, and 1, 2, 3. It's 5 to 7. It is 1 and 2. 8 to
this patient. Creatinine is 5. 22 bilirubin, PTINR was 1.4, 1.16, and
lactate value. It's a stage 3, sir. Hepatic stage 3. So in a stage 3 with more than.
Here the patient's bilirubin is persistent. Okay.
Yes, sir.
What do you do next? So you are thinking of an autoimmune liver disease, but we are not. The score is not correct. Well, score was not very. Is not even touching either. It may be just probable, and she had an infection. She had a CAM. She had an infection, but bilirubin is persistent.
So maybe going for a liver. I will consider the earlier LT liver transplant in this patient.
Liver transplant in this patient. You are bugging yourself.
Yes.
Here is a patient who got a CKD. Stage 5. So you will do only liver transplant?
No, sir. Liver kidney transplants, actually. Both.
So liver kidney transplant. You don't want to look at a biopsy. Patient is fertile. Kidney. She's got a kidney disease. She's on stage 5 kidney disease. So you want to do a liver transplant in her, or do you want to look at the biopsy? So here is a very frail patient who has got post CABG. You think you can just post her for liver transplant and get it done? She'll be one of the highest in this.
So I will
go for the liver disease. Is it autoimmune liver disease?
Yes. I will check the biopsies and actually go for a.
What biopsy you will do?
I said
Platelet
transjugular
count is
biopsy
162, 1,62. The PTNR is 1.16.
with acetyltransjugular
Transjugular liver biopsy. Okay. This is her notes on transjugular liver biopsy from our cath lab. Yeah.
suspect. So findings are right hepatic.
You're right. We suspected autoimmune hepatitis and we did it. Okay.
Okay, sir. The finding, it showed a right hepatic vein was assessed through the purpose of catheter and free wedge hepatic pressure were obtained. Free hepatic vein pressure was 24 mmHg. Wedged hepatic venous pressure was 14, and hepatic pressure gradient was 10.
So
And
does she have portal hypertension?
Yes, sir. Yes, portal hypertension, sir.
So we have done the biopsy, thinking it could have no, because you said IgG were elevated. It was the scoring was not coming right up to the 6. So we did a biopsy to see what exactly is happening to the liver. Okay.
Yes.
And she has got a hepatic wedge pressure gradient of 10. What does this show? What stain is this? What stain of this? Who is taking up this?
Hello, sir.
Yeah, please tell me.
Sir.
What stain is this?
I don't know, sir.
Amoxicillin esophilia. Amoxicillin eosin stain, HE staining. Okay, you are already in intracellular canalicular cholestasis and intracellular. See, these are the things you see a bile plugs here. So these are all the cholestasis of the canaliculi. Okay.
Yes, sir.
And as you go here, you can see narrowing of all the sinusoids. Then you can see some intracellular cholestasis. Some of these are canalicular. These are the bile plugs which shows in the canaliculi. Okay.
Yeah.
So there is intracellular and canalicular cholestasis in this patient. There is no inflammation. There are no plasma cells. There are no much of eosinophils. Okay.
Yes. Yes, sir.
So these are the ducts. I don't know if you think these are all the ductular
Yes.
proliferation, and you see so much of inflammatory cells with neutrophils, lymphocytes, and occasional eosinophils. Occasional eosinophils. So there's a ductular proliferation. There is no evidence to say that there is a primary biliary cirrhosis or a sclerosing cholangitis. There's nothing to suggest the patient has got any autoimmune hepatitis. So there is a bland cholestasis, intracellular thing, but at the same time there is ductular proliferation injury with lot of inflammatory cells. This is what is MTS stain? Mason trichrome stain.
Trichrome stain, sir.
These are all the big fibrotic tissue. These are nodules. These nodules are not seen completely. So this patient has got a bridging fibrosis. Okay?
Okay.
Fibrosis with incomplete nodules, with occasional nodules. When you have occasional nodules, we call this as incomplete cirrhosis. So what she has is an intracanalicular and canalicular cholestasis. There is some ductular proliferation, ductular injury, ductular proliferation to produce ductal thing, but there's nothing very classical of PSC or PBC or autoimmune hepatitis. They did look for IgG4 staining in this. IgG4 staining was negative. And when you do a MTS stain, you found that there are occasional nodules, one nodule here, one nodule here, and you can see a lot of bridging fibrosis. But there are no plasma cells, very few occasional this thing, or lymphocytic infiltrate to suggest there's an autoimmune hepatitis. Okay?
Okay, sir.
Can you read this?
Yes, sir. Microscopic appearance section studied shows fragments of liver tissue with a phased architecture. Hepatocytes are arranged in a nodules, macro and micro, separated by thick fibrous septae. The hepatocytes exhibit mild steatosis and focal feathery degeneration. Intracanalicular and intracellular cholestasis is noted. There is widening of portal tract by fibrosis. The lymphoid infiltrates are noted. Portoportal and portocentral fibrosis with the ductular proliferation, and there is no interface hepatitis, increased plasma cells, steatosis noted in the section study. Diagnosis given showing bridge and fibrosis with the incomplete cirrhosis.
Because the nodules were far and few between, there are multiple things, so it is not a classical, so it's incomplete cirrhosis. Probably it's moving on to cirrhosis, but there's a definite bridging fibrosis. Now look at this, there is no interface hepatitis, there is no plasma cells, there is no steatosis. But you cannot say when the patient has gone for bridging for the NASH could have become, it could have been a, so this could have been a burnt out NASH, or it could be a, what else could it be? What else can, she has taken some CAM.
Yeah, so possibility of obstructions, sinusoidal obstruction syndrome.
Sinus obstruction is so. What in CAM can produce? So what do you do with that thing? So patient has come to you and said she has taken CAM. So what do you do next? What is the other thing, interesting thing you can do?
I can test the CAM, which content of
This is the first thing what she took. This is the first medicine what she took for 3 months. We send it to our pharmacovigilance in the department of, in the pharmacy college of PSG. Look at this. The first one contained natrum sulfuricum. There was absence of colding. The next one was called Regvac Hepagel, which had alkaloids. We test for alkaloids, steroids, and heavy metals, but there was alkaloids. The second sample, which you took for 21 days, also showed lot of
alkaloids.
So alkaloids can cause
the sinusoidal obstruction.
It can cause portosinusoidal vascular obstruction. It can cause veno-occlusive disease. It can cause acute hepatic necrosis. It can cause bridging fibrosis. So that is why even though her platelets, everything were normal, she did have a portal hypertension, mainly because you see that there was a, in the biopsy, you will see that there is a portal and portocentral fibrosis. They are very close signs. So the sinusoidal fenestrae would have got closed, and that could have produced a sinusoidal portosinusoidal vascular disease. This way. So this is what has happened with this. Okay.
Okay, sir.
So as the bilirubin was not coming down, we put her on a plasma volume exchange because her ferritin went up to 2630. Counts were still up in spite of there was bilirubin was not coming down, despite the infection being treated and cultures were negative and procal was never thing. So we thought probably there was also a macrophage activation. And so we put her on a plasma volume exchange. Look at this. After 5 sessions, bilirubin was 6.6,
albumin of 3.8, and creatine 4, and there's a gradual decrease.
Ascites. Much more alert, able to eat well. So the final problems was it could have been she has got a cirrhosis of liver, which could have been a burnt out NASH. We can't say, because once there is a fibrosis cirrhosis, the steatosis will disappear. The second possibility could have been a drug induced by the CAM. You see, out of the 6 medicines, 4 contained plant alkaloids. Plant alkaloids can cause acute hepatic necrosis. They can find a limiting bridge. They can produce portosinusoidal vascular this thing. And here you can also see that portal, and portocentral fibrosis which could happen. And there was also a drug-induced cholestasis, isn't it?
Yes, sir.
And you saw portal hypertension, despite having a normal platelet, probably it was a recent portosinusoidal vascular disease, as evidenced by your wedge pressure gradient of being 10, and with grade 1 varices. Okay.
Okay.
How many days you require in a silo obstruction to develop varices? 19.2 days you can develop varices. She had ACLF probably triggered by
One is infection and one is delay. Two
DILI,
possible
drug-induced going to ACLF, and there was a transient worsening of this ACLF due to a urinary tract infection.
infections. And chronic kidney disease, diabetes, and coronary artery disease.
Okay.
Okay.
You can consider transplant, but if you consider transplant, you need to do a simultaneous liver and kidney transplant.
Kidney transplant.
Okay.
Okay.
I think that's the end of the case. Dr. Varghese, Dr. Roche,
Okay.
Madam.
Professor Venkat and Professor Jayanti, please tell us the learning points from this case.
So the learning points here is, I think, what are the ways that first you need to know the diagnosis of DILI. What are the ways, as Madam was asking Dr. Jayanti Madam about what are the ways a DILI can in liver injury. The third thing is, why Jayanti? Third thing is, in this case, that this is a complication of a cirrhosis, and we need to look at the causes of cirrhosis, look at what is the triggered ACLF, and biopsy findings of a plant alkaloid causing the liver damage, and probably the management.
I think they should know everything about drug-induced liver injury, the Hayes law, the R factor,
Hayes law, Rocam's criteria,
Rocam's criteria,
Rocam's scoring.
yeah, and autoimmune or drug-induced autoimmune hepatitis is the other thing that they should know, and then differences between veno-occlusive disease and sinusoidal obstruction syndrome. And I think that basically, if this case was kept in the exam, the focus would be more towards drug-induced liver injury and diabetes-related NASH and its complications. That is underlying NASH progressing to cirrhosis and DILI superadding, which is responsible for the failure.
It is important
like about 15 to 20% will never get the history. Here, at least we got the history that the patient was taking some drugs. But sometimes, despite the best of efforts, you may not get the history at all. So I think when nothing is there, then consider the possibility of an unknown cause and keep drug still as one of the possibilities.
Dr. Roche, you want to make any comments?
I think one important when a student should know the definition of ACLF and other what are the triggering factors of ACLF and what are the common causes of ACLF, and how to go about managing the ARC criteria in the importance of ARC criteria, R criteria in the management. And also the definition, sometimes, the timeline and the other criteria involved, the chronology of the development of symptoms of this thing. So I think all the students should look at the APASL guidelines for the ACLF. This would give them good information about how to go about in ACLF cases.
Okay, thank you very much. Thank you, Dr. Ravi Kiran and Dr. Sadish for discussing the case. And apart from APASL, one should also look at the ESL cliff also, because some of the examiners prefer the European criteria and not the APASL criteria. So I think the students will have to be very diplomatic. Some examiners may be APASL oriented, some people may be ESL oriented. So they should know both and maybe say it is given like that, it is given like that, and be diplomatic, because as per APASL criteria and as per ESL criteria, the diagnosis of ACL differs slightly.
Right. Infections are included in ESL.
Yeah.
Infections are not included in APASL.
Okay, can we move on to the next case? Yeah, it has to be fast. Can we move? Dr. Amnish, are you there? Okay. we have today. Please read it, Dr. Amnish.
26-year male, sir. Yes, 26-year-old male patient with no prior comorbidities, yellow discoloration of urine and eyes for 20 days, associated with the anorexia and weight loss, and there was no fever, and there was an early study and weight loss. He is a known case of hypothyroidism.
Yeah. Tell me, what else you want to ask him? This is a short case.
Yes.
So 26-year-old male, he has come with
Sir,
yellow to the urine eyes for
ask for
20 days,
the
anorexia, weight loss, no fever, early sudden weight loss. So,
sir, any abdominal pain, associated abdominal pain there?
no abdominal, vague pain in the right upper quadrant.
Or any pruritus, sir, and
No
stool color?
pruritus, no pruritus.
Ramesh, think that you are in front of the patient and just ask what the standard question which you will ask in a short case. Fast. You have to be very fast.
Stool color, sir. Yes, sir.
Stool color was normal. There was no pruritus. There was no clay colored stools. It was quite okay. And suddenly he has come with low discoloration, urine eyes for 20 days.
Or any past history of jaundice, sir. Recurrent
Pardon?
jaundice.
Pardon?
Past history of jaundice, sir.
No previous history of
Recurrent jaundice.
jaundice, no travel outside,
Alcoholic history, sir.
no history of any alcohol intake.
Jaundice, sir.
No, I'm not able, you're not very clear, doctor.
Sir, any family history of jaundice, sir?
No family history of jaundice, no. No family history of liver disease either.
Any drugs?
So he had an acute onset of yellowishness of the eyes.
Yes.
And he was okay. He had anorexia, weight loss. So it's something like he developed a prodromal onset of jaundice in a 26-year-old patient.
Yes.
So what are the possibilities?
Sir, any abdominal distension, any Bull-Chiari syndrome, sir, to
There
rule
was
out
no
acute
abdominal
jaundice is
distension,
there,
there
sir.
was no pedal edema. He was feeling extremely tired. He was not able to eat food, so he came to us. And there is no pedal edema, there is no abdominal distension. Anything else?
Any cough, sir, any past history of tuberculosis? Sir?
No past history of tuberculosis. There is no GI bleed. There is no altered sensory.
It was evaluated elsewhere.
What are the possibilities here? This patient, 26-year-old man, comes with 20-day history of jaundice, anorexia, weight loss, vague right upper quadrant pain, yellowish discoloration of eyes and urine, no clay colored stools, no history of alcohol.
Sir, any
So tell me what are the
infiltrative
possibilities?
disorders, sir?
26-year-old guy
Bull-Chiari
confused.
syndrome.
It is
Ramesh, your sound is not very clear to us. We are
sounds
temporarily,
are not clear today. I don't know.
so we are temporarily going to Aniket. We will get back to you later. Aniket?
Sir.
Okay, you have heard the history. You have heard what Professor Venkat has been asking. So you please answer quickly.
So he is 26-year-old male with jaundice and weight loss.
No, you tell me the differentials. Here is a man who has come with, comes and tells you yellowish coloration of eyes and urine, anorexia, weight loss, vague right upper quadrant, right, for 20 days. So what do you think? What will be your differentials in this patient? There's no abdominal pain, there's no fever, no chills.
First is
What are you
no.
thinking, doctor? What is the viral? 26-year-old man comes with a prodromal of also on jaundice. What are the possibilities?
First is viral hepatitis.
Viral hepatitis, very simple, no?
Yeah.
What viruses can come with this prodrome? What viral hepatitis can come with prodrome?
So hepatitis B,
Hepatitis B.
hepatitis
What
A,
viral
B,
hepatitis will come with a
E,
prodrome and acute hepatitis?
hepatitis A, B, E.
A, B, E. What about C?
C can present with acute, but
Did we
that
get
is rare.
prodrome and all acute hepatitis C?
No, sir, less likely, sir.
It's like it usually does not come. 80% something. Majority of the acute hepatitis C comes off as asymptomatic and goes away. Okay. Then what other hepatitis can come with prodrome? What about will all the tropical jaundice come with the prodrome? Any other viruses
It can be,
with
sir,
hepatitis
like dengue fever and also
dengue with high swinging temperature, HSV, CMV, all these things can come, isn't it? Lepto, dengue, malaria, and all will tropical.
Yes,
they come with very, very high swinging temperature. Okay.
Yes, sir. Yeah.
What is the difference between that jaundice and how do you differentiate that this is hepatotropic jaundice or non-hepatotropic tropical jaundice?
In hepatotropic jaundice, the fever the jaundice will subside after onset of the fever subside after
of jaundice, the fever subsides.
Yeah.
The fever persists with jaundice. It can be sepsis. It can be hemophagocytic syndrome. It can be
non-hepatotropic jaundice.
Dengue, malaria, salmonella.
CMV.
Okay.
Yes.
Okay. So one is viral hepatitis. What else can produce? What else can come just like a viral hepatitis? Drug-induced liver injury, isn't it?
Yes, sir. Drug-induced liver injury.
Drug-induced liver injury can completely mimic viral hepatitis. Number 3.
Yes. It can be Wilson's.
Wilson's
first.
Also, yeah, it can be one of the first attacks of Wilson's. Then.
We should ask about the alcohol to know whether it is.
No alcohol. I written no history of any alcohol intake.
Okay. Yes, sir. No.
Okay. Alcohol hepatitis. Okay. That's also can come to you like this sort of prodrome. They can come with fever. They can come with tachycardia. They can get a very upper range. Good. Alcohol.
NAS also less likely.
What is it? NASH.
NAS is less likely, sir.
What is it? No, how can you ever
non-alcoholic
steatohepatitis with acute hepatitis, man?
No, sir.
How do you classify non-alcoholic fatty liver disease?
Non-alcoholic steatosis, steatohepatitis, and
one is non-alcoholic fatty liver disease where there's simple steatosis.
Yes.
Then you have NASH,
steatohepatitis,
where there's an inflammation. Then
cirrhosis.
NASH fibrosis. Then NASH cirrhosis.
Yeah.
Okay. Just go read about the guidelines and EASL guidelines of NASH. How do you classify NASH, right?
Yes.
Okay. Acute Budd-Chiari is a possibility.
Acute Budd-Chiari, yes, sir.
Subacute Budd-Chiari can also come with or jaundice, vague upper thing, pain, all those things. Okay?
Yes.
Okay.
He was evaluated elsewhere where his HB was 8.7 low. LFT showed 9.8 total bilirubin, 9 direct bilirubin.
147 was SGOT.
Yes, and SGPT is 59, 138 alkaline phosphatase, 6.8 total protein, 2.4 albumin, and
4.2 is globulins.
Yes, and 431 is gamma GT.
Was gamma GT.
So here the patient had developed mild fetal edema. Ultrasound showed normal liver, and patient took a CAM 7 days. and he was referred for further evaluation. Here the patient has direct hyperbilirubinemia and low albumin and high gamma GT.
High globulins, mildly elevated alkaline phosphate. Our thing alkaline phosphate 119, and she has had a SGOT more than SGPT.
Yes, sir. On examination, patient was a conscious oriented, afebrile, pallor present, icterus present, mild pedal edema present, hemodynamically stable, large palpable liver is there, form 27 centimeter of liver span, spleen palpable and no free fluid.
So he had no ascites, he had no he had a very mild pedal edema. He had pallor. Icterus was present. There was a very large, firm, palpable liver, 27 centimeters. Spleen was just tipped palpable. Any other clinical findings you want? So large liver.
Liver, your margins are smooth or it is
Smooth margins,
irregular.
firm liver, slightly tender.
And gallbladder, we can palpate.
Gallbladder is not palpable. Why do you want gallbladder? No, why do you want gallbladder, doctor? Why did you ask for gallbladder? Nobody's answering. Okay, the gallbladder is palpable. You mean to say this? Do you get 27 centimeters in obstructive jaundice?
No, sir. It should be hepatocellular jaundice.
So that means here is a large, massive hepatomegaly.
Yes.
With anemia, with jaundice. Spleen is just palpable. There's no free fluid. Okay. What else you wanted? You want to look for veins, no? Is there any back veins? This thing?
Yes, sir. Abdominal veins and back.
JVP.
JVP, yes. Yeah.
Why is JVP important? Tell me.
In case of
how do you connect JVP and large liver?
In Budd-Chiari syndrome, sir.
Budd-Chiari syndrome, okay, there will be loss of. In Budd-Chiari syndrome, what do you want to look at the JVP?
JVP can be elevated, sir, in Budd-Chiari syndrome. And loss of hepatojugular reflex.
What do you look for in Budd-Chiari syndrome? In the JVP, what is that reflux called?
Hepatojugular reflex will be lost.
Present or absent?
Absent.
Yeah, that's what one thing. Supposing this patient is, when somebody has got a large liver and a very grossly elevated JVP, where do you get this? Tender liver.
It can be a cardiac disorder also, sir, like
what cardiac disorder?
Constructive pericarditis or severe tricuspid regurgitation.
Or?
Severe tricuspid regurgitation and CCF also.
Restrictive cardiomyopathies. Only there you can develop big this way. Okay, constructive pericarditis. Okay. So there's a large liver in this. So these things. So there was no elevated JVP, everything. There were no veins here in this patient. Good. So here is a patient who had an acute onset of prodromal onset of jaundice. He had acute yellowish discoloration and eyes. He had anorexia. He had not able to eat, mild pedal edema, and he's got a large, firm liver with no evidence of hepatojugular reflux or a cardiac element, but he's got anemia and icterus. He is not an alcohol. He has just taken camp for 7 days. He says he doesn't take alcohol. So what are the possibilities?
It can be some myeloproliferative disorder also.
Tell me the differential. Also, now tell me the differential diagnosis. I'm giving you a thing. You're not a thing. You have to tell me. See, these summing up, you should do it. Okay.
Yes. First, I will think of the acute viral hepatitis.
Viral hepatitis, how often have you seen 27 centimeters of liver?
No, sir. Then,
Then, like, have you seen 27 centimeters of liver?
no, sir. No, sir.
Which viral
No, sir.
hepatitis you have seen? So we are
This
talking about differential diagnosis of a massive hepatomegaly.
But
You tell me the DD for this patient, 27-year-old man with a firm liver, which is 27 centimeters a liver span with no clinical evidence of constrictive pericarditis or a Budd-Chiari. Or say, okay, have Budd-Chiari as one differential. What are the other differential diagnoses?
sir, myeloproliferative disorders.
Myeloproliferative disorder,
Like a chronic myeloid leukemia or polycythemia vera.
Okay. Myeloproliferative disorder. Number 2. Number 3.
It can be lymphoma also, sir.
Lymphoma. Number 4.
It can be
Can it be a myeloma?
yes, myeloma, so we can get large liver.
Can it be an amyloidosis?
Amyloidosis, yes, sir.
Storage disorders?
Gaucher disease,
Gaucher's, then
diseases can be there. So
alcohol
malaria,
liver disease.
alcoholic liver disease can be.
Can get large livers. Then
Malaria can happen.
where are the malignancies where you can get infiltrative, where you can get large liver? One is lymphoma. Number 2.
Lymphoma, myeloproliferative disorders. Then large FCC can also.
Malignancies.
Yes. Very large HCC, sir.
Melanoma, malignant melanoma. Melanoma, metastatic liver disease melanoma can have large livers. Never rule out any malignancy. Sudden infiltrative, some of these malignancies come as an acute hepatitis. This is very, very favorite statement of Julia Wendell. Once we were surprised when she said this is malignancy. That's our experience, and this turned out to be a malignancy. Okay, so you can have we can have Budd-Chiari, myeloproliferative disorders, alcohol liver disease. You can have amyloidosis. You can have storage disorders. Okay.
Yes, sir.
This one. This patient did not have any pruritus or anything. So these will probably the differential diagnosis for this patient. So what about the investigations?
First, we'll see the routine blood test CBC, HB 7.1, MCV 120.3, total count 20,000 elevated with neutrophilic predominance. Platelet count is normal 394,000, and peripheral smear showed macrocytic normochromic anemia with neutrophilic leukocytosis. Increased rouleau formation, corrected reticulocyte count 7.3%, and PTINR 1.35.
So you got a macrocytic normochromic anemia with neutrophilic leukocytosis. Yes, MCV is 120, corrected reticulocyte 7.5. There is increased rouleau formation.
Yes.
PTINR is 135. ESR was 124.
Yes. That is very highly elevated.
Huh? What is it?
There's
got a macrocytic anemia. She's got a normal platelet. Okay, let's go. Say there's increased rouleau formation. What else you want next? What are the other investigations you want?
LFT.
Yeah.
You are 16, creatinine, total urea 11.5, direct 10.
Wait.
Direct 10.9, OT,
This is 172 is SGOT.
Yes, SGPT 72, and alkaline phosphatase 195, total protein 6.6, and albumin 2.2, and globulin 4.4, and gamma GT 248. COVID negative, electrolytes normal.
Wait. You interpret, man. Why are you running away like that? Interpret this.
So here is a direct.
It's got a direct bilirubin. SGOT is more than SGPT.
Yeah, with low albumin and elevated gamma GT alkaline
You got
phosphatase.
elevated alkaline phosphatase. You got a gamma GT is elevated. There's a low albumin and very high globulins, isn't it?
Yes.
And he has got an increased rouleau formation. You got anemia, high ESR, MCV of 120.
Yes. It
Yeah,
is again
go ahead.
going towards the myeloproliferative disorder. So,
Let us see. Go ahead. So she's got
ferritin is
and they've
6.
got a large liver. Okay. So large liver, there is an SGO is more thing. There is also a cholestatic picture, low albumin and high globulin. Okay.
Serum ferritin is 665 and iron serum iron 49. Ceruloplasmin is 40. Normal TSH is 6. T3 T4 normal. Anti-TP
He's a
is
known
100.
patient with subclinical hypothyroidism. He was on treatment with thyroxine. Yeah.
Yes. Anti-TP is 100 and vitamin B12 215.
Why
250.
did we do B12?
Because a macrocytic anemia is
Yeah,
there.
good. Microcytic.
And
Direct
direct Coombs
Coombs
is
is positive.
positive.
We got
Viral
anemia,
serology.
high retic count, MCV is elevated. Direct Coombs was positive.
Viral serology negative and ANA profile and liver ISG profile negative.
So basically, she's got a low B12, Coombs positive hemolytic anemia, and she's got a picture of both hepatocellular and a cholestatic picture in the liver, bilirubin.
Zero
Okay,
function.
the LFT. Prothrombin time was normal, platelet counts were normal. Okay.
Yes. Yes.
He had already had an ultrasound elsewhere which showed fatty liver.
Yes.
So we thought we
It
just.
is
Why do you think I did a CT liver in this CT for this patient? What do you think I was having in my mind?
any vascular thrombosis or like portal vein thrombosis?
Vascular thrombosis. Clinically, there was no vascular thrombosis. What would have been striking? Here is a patient, young man, who has come with acute onset of jaundice, weight loss, not able to eat, massive liver, hepatocellular and cholestatic picture, anemia, high ESR. You said in one of the differential diagnoses.
Lymphoma was one of differential, sir.
Very good. So I think
You see the
we were looking at some infiltrative, anything like a lymphoma. So we did a CT. And what would I have been interested for a lymphoma if it had been a lymphoma? What do you think I would have been looking at? We did a CT thorax and CT abdomen.
we have to rule out tuberculosis. We can rule out tuberculosis.
Tell me, what do you think I would be looking out if it has been a lymphoma in a CT? What are the findings I would have expected? I would be expecting
Periportal lymph nodes or
multiple enlarged lymphadenopathy, both above and below the diaphragm. Then,
and then
you
portal
have
thrombosis.
27 centimeters liver.
Whether any infiltrations in liver or not.
What liver? What will you see in lymphoma and liver?
IHBRD.
If there is been a nodes, I think they would have been looked for an IHBRD if there is a portal nodes, or you would have looked for a diffuse altered ecotexture of the liver, and then most importantly, you would have looked for a spleen. All those things we look for. Okay.
Yes, sir.
This liver, what do you see?
Here, the first image is the arterial phase. We can see grossly enlarged liver.
Yeah. And you can see areas of hypoattenuation.
Yes, sir.
Due to differential perfusion. And here you can see that there is a predominantly a fatty liver. There's nothing. There is no IHBRD. The vessels were normal. There were no nodes. Spleen was mildly enlarged. There was nothing. There was minimal ascites. Okay?
Yes.
Okay.
CT report shows a massive hepatomegaly with severe fatty infiltrations. There is no focal lesion. Gallbladder distended, pancreas normal, spleen 14.3 centimeter enlarged, both kidneys are normal, all the arteries are normal, no lymphadenopathy, no free fluid, no wall thickening stomach, anterior abdominal wall normal, others are normal.
So massive hepatomegaly with severe faulty infiltration and splenomegaly in a 27-year-old patient, non-alcoholic, with anemia, Coombs positive anemia, hepatocellular and cholestatic pattern, negative viral serology, and and there is increased rouleau formation and increased globulins.
This is still the first
There's no evidence of
differential.
lymphoma here, isn't it? Are you agree? There's no evidence of any.
No, sir, no
There
lymphoma.
are no nodes above and below the diaphragm. There's no thickening anywhere.
Yes, sir, no lymph nodes.
So here there is
Sir, in-
anemia, Coombs positive, high retic count, high ESR, increased globulins. The pattern is different. So you said you wanted to rule out a myeloproliferative disease.
Yes, sir. We
High
can do
globulins,
JAG.
high ESR, increased rouleau, anemia. What do you think you want to rule out?
Polycythemia vera, sir.
Right?
Polycythemia,
Your total RBC count was normal.
yeah.
Polycythemia vera will have proliferation of all the three. No, platelets will be elevated, total count will be elevated, and this one is elevated. Here there is anemia. Total count was normal. Platelet count was normal. Where do you get
And-
increased rouleau formation? So you are left with, there is no Budd-Chiari, there is no lymphoma in this. So you are left with myeloproliferative.
Yes, sir.
You are left with myeloma, amyloidosis, isn't it?
Or
Isn't
storage
it?
disorder. Yes, sir.
Yeah, storage disorder. Viral hepatitis is not, all the viral hepatitis are negative.
Yes, sir. That rules out.
So what do you do next?
We can.
We did
upper
endoscopy. Endoscopy
Yeah.
showed
It is showing small varices, sir. Small
this is
esophageal
small
varices.
varices. There's nothing.
Protein
So we
electrophoresis
went and
showed.
did protein ultraphoresis. No? Globulins are elevated, rouleau formation, anemia, then so what could be the possible? So we thought, could this
Myeloma,
be
sir.
myeloma or an amyloid?
Yes. Protein electrophoresis showed marked hypoalbuminemia with a polyclonal elevation in gamma globulin. Serum immune.
Why do we do a
mixed-
serum immunofixation? What are the things you can see in a serum immune fixation? You can look at the albumin, you can look at the globulins, all the 4 globulins. You can look at the light chain, no? Kappa and
Yes, sir. Kappa lambda.
lambda.
That is
Kappa and light
elevated,
are
sir.
mildly elevated. Beta 2 microglobulins were
Beta 2 microglobulin is 2498.
2460 is normal, 2498, but myeloma band is not detected. And this is
And,
suggesting predominantly of a what is it? So there is no multiple myeloma. It is presently of a polyclonal gammopathy. Okay?
Yes, sir.
Okay?
Yes, sir. Polyclonal.
So there is no myeloma. So the next one is serum alpha antitrypsin we did because he's a young chap who came with hepatomegaly. I think it was normal. His sugars were always normal.
Yes, sir.
So when we are waiting for this immunofixation, we did a, because there was a
Bone marrow
plasmacytosis, we did a
bone marrow aspiration. Which a trypsin biopsy, bone marrow biopsy, it showed a bony trabecular fragments enclosing 4 to 5 partially preserved cellular marrow spaces. These spaces show erythroid precursor with predominant megaloblastic maturation. Myeloid series show sequential maturation. Megakaryocytes are normal in number morphology. Increase in mature plasma cells with focal clustering are noted. There are no atypical cells seen in the section studied.
and
Congo red.
negative for amyloid.
amyloid.
So when we
Both-
did endoscopy, do you think you would have done something to rule out amyloid? What other biopsies you can take to rule out amyloid? You can do an upper GScopy, take a duodenal biopsy, and what are other
Duodenal biopsy.
places where you take biopsy to rule out amyloid? Tell me
Rectal,
3 other places.
rectal biopsy, sir.
Rectal, biopsy from the lip, and biopsy from the abdominal fat.
Yes.
All this you should come out, doctor, very fast, okay?
Yes. The rectal duodenal biopsy showed fragments of rectal mucosa.
They did
which
not show
present-
anything. They didn't show
Okay.
anything. So they did not
No
show
fat.
amyloid. So there was no amyloid. But there's a massive hepatomegaly. But there was no amyloid in this, amyloid this time. So viral serology negative, non-alcoholic, alpha-1 antitrypsin, but he's got anemia, plasmacytosis. But since the light chain and both the alpha and kappa were elevated, we thought this could be a
monoclonal gammopathy of unknown significance.
unknown etiology or a light chain disease. Okay,
Yes.
you heard of light chain disease of the liver? Light chain amyloid, non-amyloid light chain deposition. That's what we thought. So alpha antitrypsin was like cellular plasmin was normal, immune marker was negative, viral hepatitis was like large liver, no alcohol. So what do we do next?
Liver biopsy.
Liver biopsy. So how do you do liver biopsy when you're suspecting an amyloid or a light chain disease?
In amyloidosis is the relative contraindication for the
So how can you do a liver biopsy in amyloidosis?
transjugular or
So we thought this was amyloid. So because percutaneous biopsy can bleed, we thought we did a transjugular liver biopsy. Go ahead.
findings showed right hepatic vein was accessed with multiple catheter, free wedge hepatic pressure obtained. Free hepatic venous pressure was 20 mmHg and the wedge hepatic venous pressure 90 mmHg. Hepatic pressure gradient 1 mmHg.
So we took a biopsy in a man who is 27 years, came with acute onset of hepatitic illness, non-alcoholic, large liver, normal prothrombin time, normal platelet count, increased plasmacytosis, cholestatic and mixed pattern of the LFT with increased gamma globulin, anemia, Coombs positive, and then he had a severe fatty liver in the liver, fatty liver by CT. There was no evidence of lymphoma. There was no evidence of Budd-Chiari. Because there was a plasmacytosis and increased globulins anemia, bone marrow did not show either a multiple myeloma or an amyloid. Duodenal biopsies and rectal biopsies were negative, but there was a mild increase in light chain and gamma chain disease. So we thought we should do a liver biopsy because we were going nowhere in this patient. Okay?
Yes. This liver biopsy showing a lot of steatosis.
What are these things?
Steatosis, fat globules inside hepatocyte.
This is macrovesicular or microvesicular?
Macrovesicular.
Macrovesicular.
Macro.
What are these?
These are micro vesicles.
So there is severe macrovesicular steatosis, microvesicular steatosis. That's all you could see in this file.
Yes.
Okay. What are these? What are these? What are these? These are classical Mallory-Denk bodies. Okay? You can see this Mallory-Denk body. These are the Mallory-Denk bodies, right?
Yes. Yes.
Okay. Mallory.
Yes, sir.
Denk bodies. And what are these?
Neutrophilic.
Severe neutrophilic.
Infiltrations.
So there are Mallory Denk and Mallory hyaline bodies with neutrophilic infiltrates. And these are all the areas of, these are all small areas of perihyalunar fibrotic areas, these areas.
Yes, sir.
What is MTS stain?
Mason trichome stain showing
Mason trichome shows evidence of,
pericellular fibrosis.
these are all the cells and there are pericellular
Fibrosis.
fibrosis. Okay. So there is macrovascular steatosis, there is microvascular steatosis, there is Mallory's hyaline body, and there is pericellular fibrosis. What's your diagnosis?
Alcohol, liver.
Alcohol liver disease.
Yes, sir.
What's your diagnosis?
These findings are typical of alcoholic liver disease. It can be NASH also.
NASH. You don't get pericellular fibrosis or intracellular canalical cholestasis in NASH. Okay.
NASH, yes.
Go read it up.
Section shows the linear fragment of liver tissue with partially distorted architecture. Hepatocytes show prominent macro and micro steatosis with ballooning and Mallory higher.
These are the areas of ballooning. Okay, these are the areas of ballooning. These are the areas of ballooning. Okay. How do you? The other thing I want to know is, this is steatosis. This is all are ballooned hepatocytes. This how do you differentiate between a steatosis and this one? A ballooned hepatocyte. See, these are all steatotic hepatocytes. This also looks white. This also looks white. This is a macrovascular steatotic hepatocyte. This is a ballooned hepatocyte.
Also, Venkat, we may have only 6 minutes left.
Okay, sir, just finishing
because the Zoom may close off automatically. Okay, please proceed.
See, the nucleus goes to the periphery in a fatty or a steatotic thing, whereas it will be still the center in a ballooned hepatocyte. Okay, that's the most important. So this patient's histology features such of alcohol etiology over NASH, but he denies alcohol.
Yes.
What is your take on that?
We should and then we should inquire about the family with the family members.
Yeah, exactly. So this boy has been taking, actually we went back and then questioned that boy, saying, the pathologist kept on telling that this is only alcohol liver disease, is nothing else. They didn't have, we sat and then we went back and questioned. So always remember, there'll be 25% of time there'll be denial of alcohol by thing. This boy was very scared about his mother and father, so he never let out the alcohol. And then it turned out that this patient was drinking about 180 ml per day for the last 3 years. And he presented with severe acute alcoholic hepatitis. The moral of the story here is that 20 to 25% of the times you should keep questioning. Just like Madam was telling regarding Delhi, that they take alcohol. And then he came out and then we questioned him in isolation. He agreed, but only thing is he was very thinking he should not tell his parents. So this is basically alcohol liver disease with alcoholic hepatitis. But anyway, the discussion should be a massive hepatomegaly in patients, in a 26-year-old boy who presents with an acute hepatitis. I think that's the end of the thing, Dr. Varghese, Rosh, and Dr. Jay.
No more slides. Okay. Ma'am, any further comments?
I think both the cases were really good, especially the second case is a typical bedside clinic or a short case, no? I think candidates should be both the candidates are all hesitant, unless you have to be very confident in your presentation, say what you know, And I think hesitancy was there quite a bit. Otherwise, it's quite a simple, straightforward case. You should be able to give a differentials for a large liver with smooth surface. So there are very few conditions when you get that, no? Large liver with smooth surface. So the differentials should be important. And that history is very, very important, no? Like even if the MCV was elevated, again, I would again think of alcoholic hepatitis, gamma GT being elevated again. So sometimes I would just tell the patient, that your labs are telling that you are taking alcohol. So you cannot dissuade that and you may have to go for liver biopsy. It's happened quite often in women patients. So that's how we make a diagnosis. Once the labs are towards alcohol, then we almost push in to the patient. Like this man would have wasted so much of money, with denial. He's gone into the investigations up to the hilt of the evaluation of massive hepatomegaly. Very well done, Venkat. A lot of questions, and I think candidates have to read quite a bit about all the stains and all. No, I think that's important.
Yeah, Dr. Roche, please.
Nothing more to add. Thank you. Thank you.
Okay, I think the mild hepatomegaly, moderate hepatomegaly, very huge hepatomegaly with additional jaundice, smooth liver, and then spleen also, mild, moderate, severe. I think this is general medicine. And in fact, even MPBS, we have such cases. So MD general medicine, we have to refresh that. And I think if this sort of case comes, they will ask definitely DD of large liver. So please read up differential diagnosis of large liver, large spleen, so medium liver, medium spleen, okay, with jaundice, without jaundice, irregular surface, smooth surface, all those things. With this, I think it is time to wind up. Dr. Sojan, please. Dr. Sojan.
Sojan has gone to have dinner.
Okay, thanks for Ravi Kiran, Sadish, Ramanish, and Aniket for joining us for the discussion. And thanks, Professor Venkatakrishnan, for that wonderful discussion. Dr. Roche for joining us, and Jayanti Madam, as always, for the support. Thank you all very much. And regarding Thursday session, there is a little doubt whether we have a Thursday session. I will let you know by tomorrow. Okay. Good night to all of you.
This,
Good night.
these sessions were just taken through so that we cover DILI, everything, the DILI and the biopsy, how we look for the steroids, alkaloids, everything. So sort of a workup, and then how you can get
Syriac, Abhi Phillips was here, he would have been much happy. If Abhi Phillips were here attending the session, he would have been very happy. The entire camp fellows are up and arms against him for his comments on DILI due to camp drugs. Okay, he's joining us next week along with the Jayanti ma'am. Okay. Good night to all of you. We will stop it now.